Recording in progress.
For grounds today, we have someone coming from the hospital to be able to talk with us. Quality improvement is a very important part of work as surgeons. We have worked to incorporate more QI into our curriculum, both for us and also for the ACGME requirements. And it's pretty good just because it does involve safety and allows us to take a look at areas that we can improve upon for our outcomes. One of these people here is Chris Linke, who was a SICU nurse for many years. He's now into management and runs the QI process for ECMO and the ICUs across the system. Dr. Brunswald has invited him to talk about quality improvements in relationship to Lean Six Sigma, and which is a common framework for our QI process, so we can become more familiar with it. Without any further ado, thank you very much, Mr. Linke, for joining us by Zoom. Mr. Linke, you may be muted.
Can everyone hear me now?
There you are.
Yes.
Hey, I see some head nods. Excellent. Okay. So I'm happy to be here today to talk to you about quality improvement. I will keep an eye on the time and leave room for some questions at the end. I'm excited to sort of share what's going on. I don't have any disclosures. I haven't figured out a way to make extra money off of this. My objectives today will be to sort of talk to you about what is quality improvement, what does it look like specifically at M Health Fairview, what is Lean Six Sigma, that's the methodology we use. I'll go more into that. I'll give a nice project example and end up with some best practice tips as well as applications for providers and for clinical staff. So about me, so I'm a principal quality improvement consultant at the U. I support the adult co-care units on East and West Bank, and then the ECMO program across the system. I'm background. I was an ICU nurse in our surgical and neuro ICU. I have been recently certified as a Lean Six Sigma Master Black Belt. Lean Six Sigma uses like belts as sort of their certification level. So there's yellow belt, green belt, black belt, with Master Black Belt at the highest. I have my master's in healthcare informatics. In addition to being a consultant for the ICUs, I'm also a coach for Green Belt and Black Belt students, as well as the Quality Improvement Collaborative. I'll tell you a little bit more about that later. I think it's a great opportunity for folks to get involved. I also work for the Minnesota Hospital Association as their SME for pressure injuries. I've been here for 25 years next month, so pretty excited. So what does it look like at M Health Fairview? I'll talk about that because that's sort of my home base, but all the things that I talk about, all the tools that we use, all the ways to do improvement really apply to no matter what healthcare system you end up at. All the same principles apply. So we like to start with sort of the burning platform. Why do we care about improvement? Why are we doing all this? You may have already seen some of these stats. The first one's been around since the early 2000s that the American healthcare gets it right, in quote, about half the time. We estimate a little over 200,000 preventable adverse events per year. Looking more locally, there are 624 hospital adverse events reported in Minnesota in just the year 2024. That's the most recently published data. We talk a lot about adverse events, but I'll say that it's not just that we look at. We're also looking at cost and how we keep function system growing. And hospital expenses have grown twice as fast as prices in just 2025, and we've seen what happens when the struggle that kind of in healthcare is experiencing with finances, and so that all ties into quality improvement too. The primary quality aims, all of our quality work is going to fall into one of these three buckets. Are we making it better? Are we improving outcomes? Examples of projects would include things like reducing adverse events. Can we decrease our collapse rate over time? Are we improving outpatient A1C levels? Secondly, are we making it faster, more efficient? Are we reducing the time it takes from door to CT in our stroke patients? Or are we reducing the time it takes for when you order a specific lab, how fast we get the results back to you or to the patient? And then finally, lower cost, less waste. We'll talk a little bit about waste, but that's really anything that's not adding value. And so waiting for open beds, waiting to get your patient out of the PACU to an inpatient bed where they belong. Reducing unnecessary documentation. It's an incredible waste of everyone's time when you're documenting the same thing in 800 places. That's waste. All those things cost time, cost energy, cost resources. And so those are all the things ultimately that we think about, that we focus on when we're talking about quality. Through all of this, the focus on quality is really on the processes, not people. And why we have a focus on process improvement, because, and I love this quote, I think about it, every system is perfectly designed to achieve the results it gets. So we have and I'll talk about CLABSI as an example later. We have the CLABSI we have because the processes we have. If we don't change anything, nothing changes. Our systems are perfectly designed to give us the results that we're getting, no matter what you're looking at. And so when we want to improve that, we have to start with the processes. Our focus is always going to be on the processes and not on individuals. We may talk about roles, but not a single person. So process is key. I also want to touch on in the beginning the differences between research, evidence-based practice, and quality improvement. I think these tend to get mixed up a bit, and it's important to call it right away. So research is really exploring new knowledge, generating new information, new literature to answer previously unanswered questions. We use the scientific process. We look at evidence. We do rigorous testing, and we discover what the right thing to do is. Taking that and moving into evidence-based practice is sort of you synthesize all the literature out there, you put together what you think is the best way to do things, and that becomes evidence for bedside practice. So we determine and implement the right thing to do. And now we get to quality improvement, which is a methodology to make sure that we're always doing the right thing, making the right thing easy to do. Now, in quality improvement, that doesn't mean we don't do hypothesis testing and lots of stats. We love stats, a lot of data, but the focus is really on making the right thing that happens every time. And as I'm going, if there's questions, throw a hand up, just speak out loud. I'm very informal. It's much more fun that way. So there are lots of ways that we have QI in the roles across the system. There are quality improvement consultants like myself all across mHealth Fairview. So we have system roles, the people that are working on what they call clinical variation reduction or care mapping. I don't know if any of you have heard about care mapping. But for example, a care mapping process might be sort of improving the A1C in diabetes patients across outpatient clinics. We also have domain QIC, so they function in the different levels. So we have a neurosurgery QIC that follows that work wherever that is across system. We've also got cancer care, emergency department, et cetera, and then focusing on reducing surgical site infections when we're looking at placing a ventriculostomy or something. And then we have unit level, like myself, where there people are supporting in ICU, South-Dale oncology, more unit focused. There's lots of collaboration between these levels and overlap, like in myself covering the adult ICUs at the U. The domain critical care person is Rory, and him and I overlap, make sure we overlap, and I'm sharing unique U projects that could then be expanded to St. John's. For example, the U a year ago this month piloted the bedside rounding, and if you've been on the UICs, you've probably seen them. Those are these big laminated boards that you can people write on and note. If we talked about certain structured rounding elements, that piloted at the U and then spread to, I think it's at St. John's and Southdale and moving forward. So that's some of the connections we have across the system. So where do we get our goals? So, where do these benchmarks all come from? They come from a variety of places. We have regulatory requirements, whether they're from CMS or from Joint Commission. We get a lot of our understanding where we should be from national benchmarking organizations, Vizient, the CDC, the NHSN, SPS, ELSO. These are all ways that we can sort of see how our peer organizations are performing, help to understand where we want to be, if we want an X percentile, or if we're leading or if we're falling behind. And we also have organizational targets, whether we want to improve patient experience, we have financial targets we want to achieve, we want to see service line growth. These are all ways that we can find our goals or understand how we're performing. And like I said, MHealth Fairview, we use Lean Six Sigma as our methodology. There are several other improved methodologies. You've heard of Agile or Scrum or other ones, but we use Lean Six Sigma. I know there's other organizations. It's actually extremely popular. Many of the top, with the Forbes 100 organizations all use it. Half of all the top 500 organizations use Lean Six Sigma, so it's pretty popular. It spans industries. You'll see this in healthcare. You'll see it in medicine. You'll see it in manufacturing and engineering. It's pretty common and not sort of domain specific. This is maybe, I think, the most important slide of all of this. A little bit of algebra. I remember from your days in high school or earlier in college, the transfer function of y is equal to the function of x. All of what we talk about really can be distilled down to this simple thing. So in y is equal to the function of x, y is our output. That's the target of all of our improvement work. For example, well, I'll get to that in a second. The output is a function of all of the inputs. So the inputs, the processes, the elements. In anything that we do, there's no magic button, there's no knob on the wall that we can do to improve our output. It's a function of addressing all the things that go into it. So, for example, a great cup of coffee, there's no magic button on the machine that's like, this coffee, I want it better. It's a function of the beans we choose, the grind, the brew method, the water temp, et cetera, et cetera, et cetera. We want to make something better, we have to address all the things that go into it. Those are things that we have control over. If our coffee is bitter, we can change how long it extracts. If we don't like it goes too fast, we can change our grind. Those are all things that we do have control over. So when I'm talking about collapsing, as I'll get to as an example later, the functions that go into that are everything from how the line is placed to the dressing type, dressing selection, et cetera, et cetera. There's going to be many, many, many of those. It's getting into those and finding your most important parts. That's the core of really doing quality improvement. And it kind of falls all back on that simple function. So the history of Lean Six Sigma starts shortly after World War II as a sort of a more organized way of thinking about things. But the concept really came together not that long ago in the 70s and 80s. It composes of two parts. So Lean was sort of developed through work at the Toyota production system, while the Six Sigma portion, methods of stats and understanding things, originated in Motorola and then GE. They added the Institute for Healthcare Improvements model for improvement in the early 2000s. And as I mentioned, it's used across the globe in multiple industries. Lean Sigma is really two things, Lean and Six Sigma. Lean is all about reduction of waste. It is a war against the things that are taking away value, and Six Sigma is about improving the average and reducing the variation of our performance. So what is waste? So waste is any activity that absorbs resources but adds no value. Even the best companies, right, they have enormous waste in their processes, over 90%. So as I said, anything that doesn't add value, that's waste. So who defines value? What is the value then in any process? So our customers or our patients, they define the value that we have. The customers can be internal or external. So for example, in a blood draw process, so you order a CBC, you want to know what their platelets are at, their hemoglobin. As a patient, it's important to know what the results of that are. So we order that, the order gets printed in the lab assigns it, the tech goes up to the patient, draws the blood, labels it, sends it back downstairs, gets handed off, moved to the machine, batched with several other pieces they get together, ran, results are done, results are put in the Epic. Lots of processes, lots of steps. The only parts that add value are the drawing of the blood, the running time in the machine to get the results, and the results being put into Epic for you guys to read. Everything else, the time it takes for the order to get sent to the individual, the travel time from the individual to the unit, all of that is waste. If we can make those things better, we reduce the waste and add value. So that's one way to think about what waste and where waste comes from. There are seven examples of waste. I'll go through these kind of quickly. The acronym we use is Tim Wood. So transportation is the distance where product travels in a process. So if I have to move a patient from one floor to the next run a procedure, that's waste. That's time that we don't need, that doesn't add value to do anything. Inventory. If we have a lot of extra stuff that's just waiting, that's waste. We got to pay for it to be stored. We got to pay for it to be managed. Things could outdate and then they get wasted. During COVID, our team was reassigned quite a bit, and we were managing all of the N95 masks because they were really kind of short in supply. And so every day we went in and we would audit and understand how many you needed for the day, and how many for tomorrow, and so we can manage in real time exactly the number of masks that we needed. And we were rounding, whenever we started our process at every new hospital, we'd go around and sort of inventory where all the masks were, who had what. And I remember one day we got to the adult bone marrow unit, and they're very particular about infection and masks. And we found an entire room with multiple cabinets stocked to the brim, hundreds of masks swirled away to make sure they wouldn't lose them. And it was all way there. And while other units were scrambling to find even one. And so it was a lot of extra inventory that was being wasted in space that they could never have gone through all of them. So we kind of redistributed those. And this example I think of when I think about sort of that inventory. Motion, unnecessary movement of a product or a person. So if you have to go from here to grab that, move it over here, to bring it back over here, all that moving around, that is waste. You know, in the surgical space, when you're trying to stay focused on what you're working on, the products are as close by as you can turn, you can grab them. We're not wasting time to leave the space, to go around, to grab things, to keep things as close as possible. Waiting, we have whole rooms dedicated to waiting. It's a huge waste. Lots of idle time. And we see this not just in the obvious space in the waiting room on entry, but all over the place, waiting for results, waiting for OR time, waiting for rounds, waiting for orders, tons of waiting. Overproduction, producing too many things than we need, very similar to sort of overprocessing or unnecessary repeated steps in a process. As a bedside nurse, there's a lot of overprocessing, and I imagine as providers, you see a lot of that, especially in documentation. I can appreciate, as a bedside nurse, the incredible burden of documentation. I imagine it's very similar for you guys. I felt like I was starting the same things in 800 places, and that's all waste. And then finally, just any defects. Anything doesn't meet customer demand, anything goes wrong. We draw a lab and it hemolyzes before we can run it. That's a defect, that's waste. We have to redo the whole process. Let's rework. There are lots of tools we can use when we're working on waste reduction. A big one is standard work. Make sure we're all doing the same things, the way we do things, the best way to get it done, and we kind of educate and make sure we're all following that. I'll kind of poke through here, but a 5S, we'll talk more about that later, but that's a way to kind of go in and set up a workspace that's functional. The things are where you want them to be. You can easily find them. You're not searching for them. They're not overmanaged. They're not out of, do we have the wrong amounts? Process maps, I'll show you one of those later. It's a big way to sort of understand where all your waste in your process is. So that's the lean section, reducing waste. Six Sigma is the other half of Lean Six Sigma. And that refers to striving for a Six Sigma level of quality. So if you were from your time in stats, when we're looking at, for example, a normal bell curve or the normal curve, we have our mean is in the center, and then this sigma is deviation or variance, and they go out in levels. The empirical rule states that from our mean through one sigma is 68% of the results. 2 sigma is 95. 3 sigma is like 99.8 or 98 point something. We want to get to 6, which means there's a defect level of just 3.4 out of a million opportunities. So we want to be as far away from our limits and reduce the number of defects that can happen. So on our graph here, if I drew a line right at the 6, and that was our specification, that was our target, we want to be at least 6 away from that. That's how we think about what Six Sigma really is. Here's some examples of different Sigma levels and how often you can expect them to happen. I would call out that airline fatalities way over past Six Sigma, which is a great example. Baggage handling is closer to 3. Just a nice sort of example. I won't spend too much time on that. We use the DMAIC approach when we look at Lean Six Sigma. So that is define, measure, analyze, improve, and control. That's the methodology. We think about how we walk through the whole process. It's an important step. It's how we kind of structure all of our work. When you're going through being certified, people have a project that's their main project they work through, and they have toll gates on each one of these steps. Check in, this is where I am, this is how we're going along. DMAIC is the sort of the roadmap for doing Lean Six Sigma. At a high level, define, you take the time to target what is the thing that we're working on, what is the scope. Projects that I would say keep things as scoped as much as possible. If you're trying to pick something to work on, if you're going to focus on something, narrower projects get finished. If you're trying to do a huge project with scope that expands all over the place, you will be working on that for years, and it is painful. Narrow is the key. Know your stakeholders. In measure, we're going to process and look at all the steps, all the data that goes into it. You know what your outcome is, knowing all the measures, and then finding the critical one. So we call that in analyze, what are the critical X's? So we identified there are 50 things that have to happen in this process. What are the ones that matter the most? What are the ones that need the most improvement? And that's where you focus your energy on. It is so important to keep an open mind when you're starting a project, because it's in nature to think, okay, I know there's a problem and I'm pretty sure the solution is going to be X, Y, or Z. Keep an open mind, because once you begin digging into this, pretty often the real opportunities, the real critical X's we say, aren't the things that we always expect. Once identified that, once you're confident you know where you want to focus, that's your intervention. That's the really fun part. You make a change or process, then you assess if that was enough. Do we need to know the level of it, redo it, make a change, or we crushed it and we can move right on to control. And control is often where projects that I see tend to miss. So you did a thing, it was great, we saw improvement, and then we all celebrate, and then we walk away. And the process, our improvement slowly drifts back to previous practice because we didn't sustain the work. We didn't set up the standard that we hold to. We didn't make sure that we're doing these things. We didn't make sure people who are coming in get onboarded and what that looks like. And that's a huge miss. So control is an important step. I don't know if maybe you heard of PDSA, or Plan, Do, Study Act, or PDCA, Plan, Do, Check Act. That's sort of very similar to what DMAIC was, sort of what they look like when we talk about the different steps that I mentioned. I tend to think about PDSA as really kind of part of that intervention. So that's where I incorporate those sort of, I'm trying the thing, and I'm going to say how it works. Common tools used in the variation reduction, the Six Sigma part. There's a lot of data analysis and understanding where we are relative to our targets. We do a lot of hypothesis testing to know, okay, is a data point really, is it just random or normal variation, or is there something special happening here? Can I confidently say that there's a correlation between these elements? Another one that I think is super important that we don't do a lot of, that I see in terms of our major reporting areas, is physical process control or control charts. They really help you know where your process is over time or between events, and also sort of what normal variation looks like versus a special event. When I say normal variation versus a special event, it's normal for a process to have some variation. So my average commute to the hospital is about 20 minutes. Some days it's 18, some days 25. That little bit of plus or minus, that's normal variation. We should not be excited about it. We should not go chasing it. We should not freak out when we're 1 minute above or below. The special cause is suddenly it took me 2 hours one day. That's totally out of the normal. It's very high. It's often 3 sigma away from our average. And usually with special cause events, you can name exactly what happened. So it took me 2 hours because it was the middle of a blizzard and it was a terrible commute. Those are the things that you can identify, know, and see if you need to make any changes on it. You can only do that if you have the good data. Getting data, I mean, we generate petabytes of data in healthcare, but sometimes getting really good data can be a challenge. If you're working on projects, people like myself or IT analytics can be your best resource to find you good data. if you want to understand sort of where we are or know more about a specific process that you're interested in getting better. It's key. So I'm going to give you a project example of at least I'm going to kind of walk you through different steps. So I'm picking collapse improvement. There's lots of projects that we work on. This is one of the bigger ones in the ICUs. This happened in the adult ICUs on East and West Bank at the EU. So we also start with the problem statement, sort of why do we care? What's the burning platform, if you will? And at the EU, we were continuing to have more collapses than we wanted to have in our target. Collapses, as you know, they can increase the length of stay, they increase mortality, they have financial loss because we get penalized by CMS. I should say collapses are central line associated bloodstream infections. I'm sure you may know that already. But so our aim statement, a good aim statement should never have a solution built into it. It should just sort of give you what your focus is, the sort of the gap, and then an end date. So our aim statement would be to reduce collapse events from 24 in 2024 to less than equal to 17 by December 31st, 2025. That's a great aim statement. Gives you exactly what we're focusing on, what our target is, what we're performing now, and we want to get it done. A great aim statement, if you bump into or attending an elevator, that's what you're working on. A simple sentence aim statement will tell them everything they want to know and sort of what your focus is. In this case, the why or outcome measures collapse events. And when we first get going and define, we don't know our process measures it. That's what we have to explore and find out what are all those X's. So we'd come back and we'd fill that in later as we get going. How many of you have heard of an A3? So a couple of hands. So an A3 is the tool that we use, and it gets used quite a bit across the system to sort of a single page document that shows everything about a project. It gets continuously updated. There are any versions or forms of an A3. There's no right or wrong one as long as it has the elements that you need on it. But this is the one we've been using for that one. I'll kind of quickly walk through it. The important things in any A3 document in, at the very top, we talk about what the project is, who's the leader. In this case, it was one of the nurse managers who was helping lead the work. We have a process owner. The process owner is not the same thing as someone who's helping lead the work. They're the ones who are ultimately sort of responsible for making sure the work is happening or responsible for the results. So in the case of collapses, which are often associated with sort of nursing care, the nursing director for the ICUs is sort of the process owner. He doesn't do all the work, but the buck sort of stops with him, so to speak. We have a variety of participants, and this is so key in any project you're working on. You've got to include the people who are at the front line. Full stop. Any work that you're working on, you've got to connect with people who do the work that you're investigating. It's super important. If I asked a manager or how X thing gets done, how the dressing team happen, I'll get an answer, but I'll get either example of what the policy is or what they think happening. And I want to know, we have to know what's really happening for the people who have to do it, because that's when you learn where the workarounds are, where things that are supposed to happen don't happen because of X, Y, and Z. So getting frontline staff was key, and then creating a space where they feel comfortable sharing the reality of it. So in our first meeting, we had 6 bedside nurses together, and the whole first meeting, we sat down together and just talked about what is hard, what are the gaps, what are the challenges in just taking care of a central line. And I'll show you the fishbone, but spoiler, we identified over 100 different yeah, I'm not sure if my screen's still sharing or if I need to reshare.
We can see it.
Oh, okay. Great. So that is that part of things. The other part is on the side, we have our sponsors and stakeholders, people who are going to help us if we need to elevate it up to higher levels. These are CNOs, our senior med director at that site, Dr. Gould. We also had infection prevention present. We had vascular access. We eventually connected to some people in the OR and the cardiac cath lab because we were having some events that the dressings weren't matching standard that come from those locations. And so we would involve them and let them know, but they were kind of out of scope for our focused work, but it's important to have them included. That's our scope. And I would say something else too, another one down about in the middle is interdependencies. This is really important because in a large organization, it's rare that any one thing happens completely in a silo. So we know that there are other work happening somewhere that might impact the stuff that we're doing. So in the case of working on central lines, there's a system committee working on that, and they may decide to change products or change documentation or change practice, and that'll influence what we're doing. So it was important to sort of call that out. And then finally, we have the bottom. It's nice to show your current or your root cause. There's lots of things you can put in there. I choose to put our fishbone. So after that very first meeting with all the staff, where we identified all those, I put it together on a fishbone that sort of put all the elements, and then I kind of affinitized them by sort of a theme, whether it was culture, communication, the process, the materials, and identifying them. And then we chose, given the opportunities and sort of where we found things, to focus more narrowly on just the dressing part of preventing collapses. And so kind of color code those, you can see where dressings kind of fit into all the different parts. The other half of that just walks through and keep updating the various milestones or actions we've taken over time. So all of that happened in define, in measure. Like I said, we got together, we identified the different items. We did that fishbone, identified, narrowed in on addressing changes, and gathered more data. This is a more close-up look at the fishbone. It's not a required thing, doing a fishbone, but I think that any way you can sort of gather all the different defects is key. The other thing is choosing dressings wasn't just a off-the-cuff decision. We used what's called a difficulty impact matrix, which is like the easiest way to sort of know, like, well, all the things we could fix, which one should we focus on first? Where the x-axis is how difficult it is going to be to make that improvement, and the y-axis is how much of an impact it's going to have on the improvement. And dressings had the highest impact, despite being in one of the more difficult areas. To be honest, especially work with like collapses or other things, there's nothing easy left to work on. It's all going to be hard work. So we felt like the highest impact, that was what we wanted to focus on first to make the biggest difference. And then we mapped out the process at the bedside. How do we go about assessing and changing the dressing? And this is what a common project map will end up looking like. So all the blue boxes are the process steps that happen. The diamonds are decision points. And for every process step and decision point, ideally I try and gather data on our performance, how long each step takes, how often we're having defects. All the yellow starbursts, those are all ways that we have variation or differences or gaps in the process. To me, I get super excited when I see a map like this. It can be very intimidating, but I see lots of ways we can make this better. So there's nothing we can't do to make this process better when we have that many opportunities to improve it. So we narrowed down to our critical X's, things that we wanted to make sure we worked on. And so we had a number of PDSAs in the intervention phase. The first one is the 5S, the supplies. The 5S is a term, there's 5 S's. I won't go through them because they're all Japanese words I tend to forget at the moment, but essentially it's taking the space that the work is happening in, making sure it's organized, making sure that the things are where you want them to be, that you can find the items, that it's clean, and then it's standardized. But we also introduced some new products because we identified that the stuff that we have to use is outdated, it's not working, there's a better tool to use, a better kit, a better item. We added a stat seal powder because the stuff that we'd use to help control bleeding there's a newer product. It works better, works faster, works stronger. We added Mastisol, we added a different secondary kit option, and then we provided specific guidance on the most common dressing challenges. And I'll show you what that looks like. We began to audit performance to identify ongoing gaps, to monitor how we're doing and engagement. And then we also added some competencies for new hires, so they were up to speed. So supply rooms. Early on in the project, we identified that if I am a nurse and I'm going to change a dressing, I have to go to the med room for this part. I have to go to clean dry room 1 for this other piece, clean room 2 for this other piece. And those areas can also differ depending on which unit I'm on. So if I'm float, now I've really got to try and find these things. So there's lots of waste just in getting the supplies. They're not where I need them to be. They're not well organized. I can walk in a room and I can't even find what I'm looking for. So we made the changes, adding new stuff, getting rid of stuff, and then we put everything in one room on each unit in the same supply area, bundle them all together and put them in red bins. So I walk into space, I can easily know this is where to find the thing I'm looking for. This is where it's going to be. And it's the exact same order and the exact same thing, no matter what unit I'm on. Super fast, reduce tons of waste. People are much more likely to use the things that we need to do to get it done because they can find them. We put a poster, we talk about what the standard is, so how to do a dressing, and then the four most common things that we struggle with to keep them clear. We walk through what supplies to get and how to approach doing it. This was kind of a key thing to make sure everyone had this readily and knew how to manage those challenges. Bleeding, peeling, or moisture. Terminal lines are their own unique challenge, both with often they may have multiple dressings, or rather lines when standard kits don't really fit, or then we have large and heavy lines. So how do you manage all those? This is a nice way, visual, simple, walks us through everything. And then we start doing more audits. And this is key because there is a system audit that goes through like the 10 bundled elements for collapsing prevention. The problem was the system element audit didn't have any detail. You either passed or failed the dressing part, and that's it. I don't know what reason that you failed it, because it wasn't labeled, or because it was like half off, or because it was completely saturated. I can't get much more out of that. So we have our own audit that we use just in our ICUs. They gave us various specifics on what was wrong with the dressing. It was passed, it was great, or it failed because it was peeling up in the corner beyond the whiteboard, or because of missing a part of the dressing that's supposed to be there. We also made sure that it was done by trained staff. And this is key because in quality improvement, we talk about there's a thing called a MSA, or Measurement Systems Analysis, which means that I can trust the people measuring it, that my yardstick is equal for everybody. So if I asked 5 nurses to go and get a weight on something, they're all going to get the same weight. Or if I gave 5 people a yardstick and asked them to measure their laptop, we're all going to get the same sort of, the same laptop, the same numbers. Is it repeatable and consistent? So getting trained staff means I know that I can trust the results they're getting. They'll all have the same expectations of what a good or bad one looks like. We recorded things like the date and time, the location, the patient details. So if I have an event later, a collapse, I can tie it back to the audits and see like, okay, well, I know that on these days it was great. I know we missed here because of this thing, and connect those, as well as staff. So if I'm seeing the same staff failing again and again and again, we can have more of a focused conversation. And then we also had a rotating teaching point where at the end of the sort of the audit, in the beginning, we'd ask them like, have you seen the poster? Do you have any questions about it? What are your most common challenges? And then control, which is an important step. We've made an improvement, and now we're making sure that we're continuing to audit and make sure our performance doesn't slip below a certain target, and that also that we never really had core education for new hires and how to do this. As often the preceptor would show them, and that was good enough. The problem is that I don't know how that education is going or if it's consistent. So now the new hires have a very set process. They do 3 dressings that are signed off by trained staff. I can guarantee that moving forward, all of our new staff know how to do the things the way that they should be done. And that was pretty key. So how do we finish? So, the end of the year we missed a target of 17, but we did finish at 21, which was better than the year before. It's actually a 16% reduction. You can see here, the green line was our target as a cumulative from January through December. The blue was how we did it the year before, and then the orange how we finished last year. And so, the beginning of the year, we were at or on target or on sort of track to be just as bad, or struggle was much as we had the year before. We actually showed an improvement. We were pretty excited about that. And for me, the fact that we missed our 70 target is okay because we still got better year over year. I'm happy to say that we've also sustained that work. December, January, and February are usually our most challenged time of the year for these kind of events. And we are, this time last year, we had already had 11, and currently we're at 5. And that's really remarkable. So it definitely has an impact. In fact, we're looking at just the ACHI part of things. Our ICUs had 3 major projects going on, but we got better in all of them, which is really remarkable. We actually reduced our total counts of events by over 24%, which is really quite something. I don't think any across system, this is quite something. So we reduced our pressure injuries, our CAUTIs, our falls. We're pretty happy about that. So what would I say to you guys in major tips, takeaways? How can you get involved? I think that there's some requirements on doing some kind of QI. The main things, so what are your individual departments or units targets, and how are you performing? The ICUs, if that's where you want to look, have multiple QI projects. We are always wanting provider involvement and input. We can look at sort of major targets. We have assigned targets in terms of like ACHI, but we also have lots of other ones, whether it's targets on sepsis or different surgical benchmarks, et cetera. So kind of certain thing that you're interested in or know we can do better on, it's a great place to start. Also, like, if you can name any of the challenges of your current workflow, this part of my job is really difficult. It's got a lot of waste. I know we're missing targets. You can reach out to your med director, nurse director, or the quality person, me in ICUs or anywhere else, and we'll connect you to some work that's already happening. There's also the Quality Improvement Collaborative, and I think this is an amazing thing. This is across the system. Every year, it's an annual training and coaching to project teams. Applications go out in late winter, and it starts in January and goes through September. Teams usually have with a sort of a focus they want to work on. And when you apply, you've got yourself, you identify a sponsor, and then for the project, there's 5-day-long training on all about like the deep dive into quality. You have an assigned coach, and you work through the project. And at the end of in September, there's a report out, attended by different executives and VPs and sort of sharing in the teams. You learn a bunch. It's super fun. You get CME credits. It's great. The number of providers go through that. They've all seemed to really enjoy it. Projects that are done or that we've done, they have been shared as abstracts and posters at a variety of conferences. We publish these in journals. Like I said, we use them for credit, and often they extend across the health system. So it's a pretty great way to get involved, and lots of sort of academic ways to sort of take things out of it as well. In summary, do always involve frontline staff. It is key. I can recall an unfortunate example just several years ago where a fellow was trying to finish up a quality improvement project, and they wanted to improve the experience of and efficiency of rounding in the ICU. And so they did some research, put together what they felt like the solution for how rounding should look, and then wanted to roll it out across the ICU. But they had never talked to anyone. And nurses were pretty upset about it, and they were a hard no because they were never included, and it was very difficult and ultimately didn't work. And I think I would say, include frontline staff, measure your data when you can, and limit scope. Scope projects get done. Keep it narrow. Know who your people are. They're going to be involved. The stakeholders, they communicate early. Oftentimes, you only get one shot to sort of explain your project, and if someone hears it as a rumor first, you're going to have to work twice as hard to get them on board. When you're communicating to someone about your project and seeking input, I would say it is key to communicate we call it the with them, or the what's in it for me. That's a big thing. If I'm working a project and I need to get people's improvement, I always want to sort of relate to like, this will help your workday, improve things, not to mention just for the patients, but also don't start with a solution. Often we're wrong about what we think it needs to be improved. And you can't simply audit your way to perfection. Just auditing is sort of defect detection. It doesn't actually improve anything. So audits are great if you want to know how your process is performing. It is not a solution. Unfortunately, we do see quite a lot of that, just more auditing. Lean Six Sigma is a methodology. In any project, we're focusing on measuring all process elements, trust the process. It takes time. Any questions? Anything at all? I appreciate your time this morning.
Got one.
Hey, I see a hand.
Yeah, so the OR is an area with a lot of inefficiency, waste, both time and resources, physical and otherwise.
Yeah.
And I'm wondering if you can speak on any particular initiatives at the university in Fairview targeting this and how residents could get involved in those aspects in the operating.
Yes, great question. To start with, I know there has been someone like me in the OR, but they've been only at the system level. So they've been stretched kind of everywhere. In January, added someone locally to the ORs. So they're here. And for us at the U, that person is Zoe. I can get you their information if you want to connect with them directly. But I also know that there's a number of different projects in the OR. The ones I'm aware of include, they are working on first case start times, which has been, I think, a challenge since the first OR ever happened. I'm not sure where they are in that process. I know it's a big one. They're also working on dealing with, they're looking at piloting a new bed warmer, a patient warmer, and sort of comparing to the current processes. I can't speak too much about some of the other specifics on the other numerous inefficiencies and waste, but I know that now we have a more local person. There's a lot more work happening. Every month there is a system level report out with the VPs on kind of what each domain is working on. But if you want to get involved, I can get you the email of some of the OR people and they can kind of give you opportunities. But yeah, a huge space rightful for improvement.
I'll ask one more question. If anybody has any interesting about this is very interesting. So I can imagine that many of our ultimate solutions are not one size fits all and over time may change. So a lot of times I think that the solutions do end up falling on those frontline workers, a lot of those people being trainees. And the trainee population changes frequently and knowledge changes. And so I'm wondering how often, if at all, the QI process or you recommend kind of checking back in on a solution or set of solutions and then making additional changes to that? Or is it really just based on if problems arise again? For example, in like CLABSIs, do you check in again in 5 years and say, gosh, our numbers have gone back up, we should reevaluate, or is it just based on problems?
Great question. It depends on a couple of things, but I would say mostly we should be monitoring all the major processes. So I know, in example, CLABSIs, I know when we have them, and so I can watch everyone change. And if we're seeing an increase beyond what expected, or if our time between events is getting shorter, I can already tell something about our performance is drifting, and that's a good time as any to check in. Other things, depending on how often we get data, there's more of a lag between the outcomes, but you can sort of see things change in the outcomes, or also there's a certain element you're following, but you have to have some kind of way of assessing if something's changed, or if you know there's been a change in the process. We changed a vendor, or we changed a major way in how we train the residents and sort of their experience in things. That's a good time as any to check back in and see what does the impact have on our processes overall. Quality improvement is continuous. So we're always chipping away at things. We're never fully satisfied. It's never really done. So always keeping track on things. That is one thing I think that we also could do as an organization better on, is making sure all those metrics are easier to find. I don't know how many of you regularly go into things like Power BI or have heard of it, but that is our repository for all the kind of like measures and data that we have as a system. I assume that other places like Regions and North Memorial and Hennepin all have something very, very similar, where they have dashboards that are showing their performance in any variety of measures. And so all of those should have sort of like a trigger to reassess things. So when I finish a project, I see, this is our current performance. If we get below X, we need to reassess things. So a good project had sort of those follow-ups. That falls in the control phase. That was kind of a meandering answer. I hope I kind of touched on some of the great points you had. Well, again, I appreciate everyone's time. I'll put my email in the chat. I'll also add the OR person's email if you want to follow up, if you have other questions. I really appreciate everyone's time this morning. Thank you so much.
Thank you.
And then it's like, matter the time. And is that data point? Like, oh, well, if they're not done by 9, then it doesn't really. Or like, if it's not done by 9, then it doesn't matter anymore. So, like, they don't go to, like, rotating people.
Oh, that's not true.
Like,
We literally have a
you
jury.
get them out as soon as you can. Like, just
We have
tomorrow.
and they'll care patients over the age of 90.
Get it.